All right, I'm seeing 11:02 on my clock, so we're going to go ahead and jump right in. Hello and welcome to today's webinar, The Intersection of Climate Change and Maternal and Child Health, Centering Global Issues and Climate Justice. We are thrilled to have you here today and that we're having this very timely conversation. My name is Laura Powis. I use she, her pronouns, and I am the Program Manager for Evidence-Based Policy and Practice at AMCHP, the Association of Maternal and Child Health Programs. For those of you who are not familiar with AMCHP, we are a national resource, partner, and advocate for state public health leaders and others working to improve the health of women, children, youth, and families, including those with special needs. Next slide, please. This webinar will be the second in a series put on by AMCHP's Global Health Initiative, an interagency work group that aims to foster innovation in maternal and child health by sharing best practices and wisdom identified from global bright spots. This webinar series, titled Sharing Global Approaches, Creating Local Outcomes, focuses on identifying and sharing culturally appropriate best practices, bright spots, and insights from the global community, including the US jurisdictions and tribal nations, with Title V and its partners. The first webinar in the series, Earning Trust, Building Vaccine Confidence, Learning from Global and Local Initiatives, occurred back in April and focused on vaccine confidence during the COVID-19 vaccine rollout. Today's webinar will explore the greatest challenges facing the maternal child health populations due to climate change. From policymaking to activism, we'll discuss the innovation of people and groups around the world working to solve the biggest issues of our lifetime. Next slide, please. But first, we want to start off with a land acknowledgement. So I would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of the local Indigenous peoples and their cultures. I acknowledge that I'm on the traditional lands of the Piscataway and Anacostan people and their tribes. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we are and can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. We are also going to be posting a link into the chat that can help you figure out the traditional tribal lands that you are on today. Next slide, please. So to start off with some housekeeping for this webinar, all lines are going to be in listen-only mode. We have live transcriptions available, and you'll see on the bottom of your Zoom window, if you want to turn those on, click the live transcription button and you'll be able to see those. You can chat into the chat box throughout the webinar and be sure to send chats to all panelists and attendees. You can also send questions for the presenters in using the chat or Q&A function, and we encourage you to do that throughout the webinar. We have time at the end for about 30 minutes for a Q&A with our wonderful panelists, which we're very excited about. So please, we encourage you to chat in your questions. And also today's webinar is going to be recorded. And if you have any technical difficulties at all throughout the webinar, please email Linda Krisawati at her email's up there on the screen, or you can also chat her. So next slide, please. With that, I'm going to hand it over to my colleague, Kay, to talk a little bit more about the issue.
Thank you, Laura. We're going to be talking about climate change in the context of maternal and child health today, because climate change is a common challenge that is already impacting the health of all communities. The United Nations has made addressing climate change a global priority by making Sustainable Development Goal 13 specifically about climate action. With 2019 being the second hottest year on record, immediate action is needed to reduce the effects that climate change is having on all types of environments. A 2021 report from the UN Intergovernmental Panel on Climate Change found that unless there are immediate and large-scale reductions in greenhouse gas emissions, limiting warming to close to 1.5 or 2 degrees Celsius in the next 20 years will be beyond reach. To put the consequences of preventing this increase into perspective, global warming of 2 degrees Celsius would put over half of Africa's population at risk of undernourishment because of the effects that climate change would have on the agriculture across the continent. And already in summer 2021, nearly 1 in 3 Americans experienced a weather-related disaster. Next slide, please. While discussing the science behind climate change is of the utmost importance, it is equally important to consider the human impact of climate change. The climate justice movement recognizes that climate change will not impact all communities and identities equally, and uses a human rights lens to safeguard the human rights of all people. Mary Robinson, founder of the Mary Robinson Foundation for Climate Justice, has described the difference between climate change and climate justice by saying climate justice insists on a shift from a discourse on greenhouse gases and melting ice caps into a civil rights movement with the people and communities most vulnerable to climate impacts at its heart. Expanding on that comparison, Vanessa Nakate, the founder of the Rise Up Climate movement and Ugandan climate activist, has described the intersectional nature of this movement by saying, climate justice is only justice if every community, every voice is listened to and amplified, especially people from the most affected areas. There is no climate justice without racial justice. In other words, while climate justice centers science, climate justice centers people, communities, and equity. Next slide, please. Climate change intersects with all aspects of family life and can affect food security, built environment, transportation, housing, and many other social determinants of health. Maternal and child health populations are uniquely impacted by climate change in numerous ways. A 2020 systematic review published by the Journal of the American Medical Association that examined more than 32 million births in the United States found that pregnant women exposed to high temperatures or air pollution are more likely to have children who are premature, underweight, or stillborn. Furthermore, African American mothers and babies experience these outcomes at a higher rate than the population at large, and minority communities all over the United States are more likely to be hotter than the surrounding areas and be located near polluting industries. To achieve optimal health for women, family, and communities, the maternal and child health workforce must work towards climate justice. And now I'm going to pass it back over to Laura to talk about our conversation today.
Thanks so much, Kay. So why are we having this conversation today, and what are we hoping to gain from it? So we're having this conversation in part to explore how climate change impacts our work as maternal and child health professionals, and why it is critical that we employ a climate justice lens moving forward as we work to improve the lives and well-being of maternal and child health populations across the country and the world. Next, it's to learn about policy and programmatic efforts underway both globally and domestically to address the negative impacts of climate change on maternal and child health populations. And lastly, it's to share global and local examples of what applying a climate justice lens looks like in action. So to that point, I am thrilled to introduce our first speaker, Dr. Jyoti Krishnakumar. Dr. Jyoti received her MSW from Mahatma Gandhi University in Kerala, India, and her Master of Science and a PhD from the Department of Natural Resources and Environmental Management at the University of Hawaii at Manaus, USA. Her academic training on natural resources and environmental management is primarily based on understanding the political, economic, and psychosocial drivers that influence environmental decisions and sustainability outcomes. She joined Keystone Foundation in Kotagiri, Tamil Nadu, India in 2017 and holds the post of director and heads up the Community Wellbeing Program. At Keystone, she works with an interdisciplinary team of practitioners and researchers overseeing implementation as well as research projects on cross-cutting programmatic areas of livelihood, community health and wellness, environmental governance, and WASH. She also collaborates with colleagues and academic partners as a part of Keystone's field courses and research alliances. Jyoti, I'm going to hand it over to you. Take it away.
Yeah. Thanks, Laura, and good morning and good evening to all, wherever you're all joining from. So I guess today I'll be talking a little bit about the maternal and child health and climate change from the perspective of Indigenous communities of the Nilgiri Biosphere Reserve. A quick outline of what I'm going to be talking about. I thought I should introduce or talk to you a little bit about the organization that I am part of, also a brief overview of the Community Wellbeing Program that I am associated with. I'm the director of this program. And I thought it was also relevant because some of the interventions that we do as part of the Wellbeing Program is sort of very linked to the kind of conversations that we are having today. Also would like to present a very brief statistic looking at tribal health status, particularly maternal and child, from the nutritional indicators perspective. Also talk a little bit about linkages between climate change, climate justice, and Indigenous maternal and child health. More from the, focusing on the nature of uncertainties, really, both observed, what we have seen on the ground, what we see every day on the ground, and also as expressed by the Indigenous communities that we work with. The linkages between forest governance and food and nutritional security, which is where I think climate justice and maternal and child health really intersect. And last but not the least, share some of our interventions in terms of addressing some of these concerns and challenges. So Keystone Foundation was established in 1993 after a very extensive survey undertaken by three friends, Sneh, Pratim, and Mateo, where they were actually surveying the honey hunters and beekeepers of Tamil Nadu, and decided to set up their first field base here in Kotagiri, which is now our head office. They started off by setting up an eco-development initiative, which focuses on strengthening or looking at these three sort of key pillars of eco-development: conservation, livelihood, and enterprise. And over time, these interventions have sort of evolved organically into various programmatic and thematic areas of intervention. I'm having something that's popped up on. Sorry, I don't know what that was. In terms of the geographic area that we work, we primarily work in the Nilgiri Biosphere Reserve, and this is a biosphere reserve that was set up as part of the UN Man and Biosphere program sometime in 1986, if I remember correctly. And as you can see, the NBR sort of cuts across three state boundaries: Tamil Nadu, Kerala, and Karnataka. The red arrows that, the points that you see are basically our different field centers and areas that we work in. And as you can see, we predominantly work in Tamil Nadu, but we do have a small operation in Karnataka and two field centers in Kerala as well. That's Wayanad and Nilambur. And we primarily work with indigenous communities. I've listed some of the names of these communities here on the slide. And these communities are classified as particularly vulnerable tribal groups. And this is based on the Government of India classification based on certain specific parameters, such as small population size, low literacy levels, and the fact that these communities most of them are pre-agricultural communities. So this is the operations in sort of the southern part of India. More recently, we have also started some interventions in eastern India. So we have an office in Jharkhand, where we work with communities in Jharkhand, West Bengal, and Chhattisgarh and Orissa through some of our partners there. As I was mentioning before, over time, what started off as an eco-development initiative with a focus on livelihood has sort of evolved into different programmatic areas. And as of now, we have sort of these three broad programmatic areas of intervention. One is the community well-being program that I'm part of. The other is the biodiversity conservation program. And the third, more recent, is the People and Nature Collective. We're also part of various network alliances, both national and international and regional. And through our interventions, we are also sort of trying to address at least 12 out of the 17 sustainable management goals. So that was just sort of a brief about the organization. Now coming to the community well-being program, more specifically, even though this is the name of the program, we also see it as the goal of the program. And the way we sort of define well-being is that, or sort of the definition of well-being that we have adopted in sort of guiding us towards this larger goal of well-being is that it is achieved when the combination of social, economic, political and cultural conditions that are identified by the individuals and the communities as essential for them to flourish and fulfill their potential are achieved then by, automatically communities experience well-being. Now, based or sort of corresponding to these different components or, listed in the definition, we have sort of corresponding intervention areas as well as part of the program. So we have interventions on livelihood, environmental governance, community health and wellness, and water and sanitation. I think in today's talk, I will sort of focus more on our interventions on governance and community health and wellness because of its sort of direct link to the, to the topic of our conversation today, which is, climate change, climate justice, and maternal and child health. Now, to talk a little bit about the community health and wellness program. It started off as sometime in 2015, following a very extensive, I'm sorry, I'm forgetting to, I was supposed to say change slides. Well, thank you, whoever is doing that. But can you go back to the previous slide, please? Yeah, so as I was saying, the community health and wellness program is it sort of started off in 2015 following an extensive survey that we did. In fact, we did it in collaboration with Cornell University. What we found was that it's sort of, I mean, we have been observing a lot of sort of health related issues among the indigenous communities here in the NBR, the communities that we work with. And we thought it was important to sort of get a real sense of what are the actual, what are the real issues in terms of health among these communities, and sort of help us identify priority areas in terms of preventive health, which is why we sort of had this survey and based on the data that was the information that the survey showed us, we were able to sort of identify and prioritize areas of intervention. And one of them was maternal and child health with a focus on nutrition, and the other was adolescent health, and the third was some sort of preliminary interventions on mental health as well, common mental health disorders. Interestingly, I also came across a statistic recently. If you could please go to the next slide. Yeah, so this basically kind of, indicates the sort of the health status of indigenous communities more from the perspective of nutritional indicators, I would say. And what it really shows is that, how the indigenous community, and this is specific to the indigenous communities of the NBR, and, how their the nutritional indicators are kind of, comparing it to the national, state, and the district levels. It's pretty, it's pretty bad, really. And one sort of wonders, why is this the case? Because you have all these different, health-related policies and programs that are specifically trying, addressing a lot of these health and nutritional related issues. For example, we have the Poshan Abhiyan, which was started off in 2018 with a huge budget of 9,000 some crores, which is about $120 million. And yet you don't see these policies being sort of, you don't sort of see these, the outcomes of these policies reflected on the ground, especially when it comes to these communities who continue to be marginalized and vulnerable. And really, when you sort of think about why is this the case, particularly in the case of indigenous communities, you kind of realize, and this realization, I guess, is based on our continuous association with these communities, is that there are various factors, social, political, cultural, and environmental factors as to why these sort of health indicators of indigenous communities continue to be at such poor levels. And in fact, I would even argue that once you sort of start connecting the dots, you would kind of see how sort of bigger and broader issues such as climate change and climate justice and social justice also kind of starts influencing or influences these, these different factors and these outcomes that you see among the indigenous communities. So I guess sort of lost my line of thought here. Could you go back to the next slide, please? The next one, please. The next slide, please. The next one, yes. So yeah, I just, so what I was saying was that, in spite of all this realization and understanding of, what is happening on the ground and our continuous association with the indigenous communities especially on our interventions through health, we have never really sort of tried to explore these linkages between climate change and indigenous health. It wasn't, at least not until recently. And to really get a sense of, on the ground, what are communities thinking about climate change? How are they sort of, perceiving this linkages between climate change and health? How are they articulating some of these changes that they see on the ground? We decided to do sort of a couple of focus group discussions with the communities here. And what I thought I'd share a few of the quotes from these conversations to kind of get a sense of how communities are, articulating these interlinkages and associations and influences. And what you see really is, across their conversations, many a time they really talk about, or a sort of a common point that comes up consistently is seasons, how seasonalities have changed, how seasons have changed, and how shifting seasons have then therefore affected their access and availability of different kinds of foods that they used to have access to before. Just to sort of share a couple of quotes from the conversation. For example, the first one talks about how before, as in earlier times, during the month of November and December, which is Kartige month, and in December and January, which is the Margari month season, it would be cold. But now in September, October, which is Puratasi and Aipasi, which is October and November itself, it is cold and raining. When we were kids, the rains was in order with our calculation, which made the availability of certain foods easier. And now that has also reduced. I think another sort of a significant quote is, for honey hunting, there will be a rain to aid in flowering, which was lesser last season. In fact, it wasn't just last season. We've been hearing about these sort of inconsistencies, we've been hearing about these inconsistencies even before. And honey is such an integral part of the, of the life of the community here. The fact that, you're not sort of having access to honey is kind of the implications of that on their culture, the implications of that on their health, the implications of that on their income is all very sort of significant, So in that way, that very simple statement has a lot of relevance and significance. Another linkage people talked about was water and climate change, and how water scarcity has affected agriculture productions, and that has sort of direct implications on their lifestyle, on their food habits, and indirectly on their, and sort of, not indirectly, but sort of obviously on their health as well. The next slide, please. This is another point that they talked about was increased human-wildlife interactions, where they, mentioned how certain food that are preferred by animals. So, for example, in this case, the elephants prefer a certain kind of, kire, which is not available anymore, and because of that, they come to the villages looking for food, and that in turn has sort of increased human-wildlife interactions as well, and conflicts and so on. Another point folks raised was on the PDS, which is the public distribution system for food, and how and its interactions with forest dependency and food security. And what they talked about was how going to the forest has reduced because of many reasons, some of them being access issues, permission issues, animal interactions and movements, moving out for work, as in migration. And because of all of this, their dependency on forest for food has come down. And simultaneously, their dependency on food on the public distribution system has sort of gone up. And the kind of food that they get from these PDS systems is things like rice and wheat and sugar and palm oil, which were sort of far removed from what they used to consume traditionally. So, when you think about it, really, from a food security point of view, this is a good arrangement. But then when you really think about things like nutritional security and the sustainability of these kind of arrangements, you sort of, start sort of questioning some of these, arrangements, I would say. The next slide, please. Yeah, so I guess the point that I'm trying to make here, or what we can sort of understand, is that, it sort of brings us to this sort of interlinkages between climate change, social justice, climate justice, and indigenous communities. In fact, one of the recent reports talked about how India is among the top 10 countries most vulnerable to climate change. And within India, communities like the Dalits and the Adivasis, which are the indigenous communities, are the most affected due to the, because the various socioeconomic policies that are designed are rarely pro-poor. And sometimes may not even sort of reach, even if they are pro-poor, it may not even really, it may not really sort of help these communities to sort of get off their vulnerable conditions. The health indicators are a classic example of that, and these are despite huge budgets being allocated for health interventions and nutritional interventions. I'm sure many of you were following the COP26 conference and must have heard of the big declarations and promises that India has made. And while these are very ambitious and wonderful and bold declarations, I think one sort of also tends to be a bit skeptical about how or if there if the plans around these big goals on zero net emissions and mitigation are going to employ a climate justice approach or not. One tends to be skeptical around that, especially because some of these plans require interventions in such big scale, in terms of afforestation and forest management plans, that it really, one would sort of wonder to what extent these interventions are going to be pro-people. And I guess it is in this context and with these sort of understanding that we sort of try and address or design our interventions on environmental governance as part of our interventions at Keystone, where a lot of our effort with working with indigenous communities has been in trying to facilitate land rights and tenure rights to these communities as part of the Forest Rights Act that came out in 2006. And this is a very sort of an important landmark legislation that that ensures communities with both individual rights at the household level and community rights at the community level. And getting these rights has such a significant outcome because it allows them the autonomy to sort of decide on how to govern their resources, how to conserve their resources, the forest resources, and so on. So it is a big sort of a significant legislation, and we've been working very closely with communities on receiving a lot of these rights. And very happy to report that a lot of the communities have received their individual rights, but in terms of community rights, the challenge has been rather difficult because a lot of it has to do with the socio-political sort of arrangements and communities are often up against forces that are much more powerful to them. So a lot of our efforts have also been in terms of identifying leadership, nurturing leadership, capacity building both at the individual and collective level, so that communities can find their voices and assert, what is rightfully theirs. So, simultaneous to these efforts on governance, if you could go to the next slide, please. Next slide, please. Yeah. So simultaneous to our efforts on governance, we've also been continuing our efforts on addressing a lot of the health issues that we see among the communities, primarily from a preventive perspective. So for example, our interventions on the maternal and child health with a thematic focus on nutrition, what we try and do is sort of revive a lot of knowledge around, healthy eating practices, talking about cultivated and uncultivated food, mapping these food sources, helping communities identify and, particularly the young people, and identifying a lot of these resources, reviving the interest in some of these nutritional meals by reviving old traditional recipes, distributing nutritional kits that contains, dry food which are rich in micronutrients like millets and so on, so that it sort of influences people in adopting these healthy food practices. And we also try and then see how these interventions are sort of impacting communities by monitoring their diets, and also through more systematic assessments, through BMI assessments and other qualitative approaches as well. And all of this work we try and do through the frontline field staff who are really volunteer health workers from the community, which the idea being that it would then sustain and the knowledge stays within the community itself. The next slide, please. This is just an example showing how we do this nutritional mapping and also an example of the diet monitoring. And then I have some photographs from the field as well. If you could just quickly run through those. I think I've already overshot my time, I'm not sure. The next slide, please. Yeah, these are some photographs of the community health workers getting trained both in-house and in the community. And these are some of our future sort of plans in terms of exploring both from a research perspective and also in terms of interventions about some of the things that we want to do. Yeah, some additional photographs of community health workers, sharing knowledge in the field sites. Yeah, that's about it. Thank you very much. The last slide, please. Yeah. Yeah, thank you.
Thank you so much, Dr. Jyoti, for that wonderful presentation. Keystone holds a special place in my heart. I have volunteered there in the past and have worked with you all, and I know you're doing incredible work. I'm very excited to announce our next speaker, Camille Delgado Lopez. Camille is an epidemiologist serving as the Surveillance for Emerging Threats to Mothers and Babies in Puerto Rico coordinator under the Children with Special Medical Needs Division of the Puerto Rico Health Department. She was designated as the COVID case surveillance coordinator on the Pandemic Response Emergency Team in the Puerto Rico Department of Health. Since 2017, she served as the Zika Active Pregnancy Surveillance System Coordinator until the system expanded into the SETMB. She earned her master's in public health with a concentration in epidemiology from the University of Puerto Rico in 2016, and her Bachelor of Science in Biology with a concentration in pre-veterinary studies from the Inter-American University in Puerto Rico in 2015. She has co-authored various reports on Zika and COVID-19 and was awarded the 2021 Emerging Maternal Child Health Professional Award. Camille, I'll hand it over to you.
Hello, thank you, Laura. My name is Camille Delgado. I am an epidemiologist. I'm the surveillance coordinator for the surveillance of emerging threats to mothers and babies within the Children with Special Medical Needs Division of the Puerto Rico Department of Health. Puerto Rico is located in the Caribbean between the Caribbean Sea and the North Atlantic Ocean. Although often referred as an island, Puerto Rico is an archipelago. formed by the main island and 143 small islands, islets, and cays. Next slide, please. How has climate change impacted Puerto Rico? The annual average air temperature has increased by more than 1 degree since the mid-20th century. Tropical storms and hurricanes have become more intense, as we have experienced in recent years. Our surrounding waters have warmed almost 2 degrees through time, and warming oceans provide storms more potential energy, increasing wind speeds and rainfall. Rising temperatures are likely to increase storm damages to coral reefs, vegetation, and homes, and are also likely to accelerate the mosquito life cycle and the rate at which vector-borne viruses replicate. Next slide, please. Now we'll talk about the climate change and vector-borne diseases in Puerto Rico. Next slide, please. Puerto Rico's climate is suitable for mosquito species that carry diseases such as malaria, yellow fever, Zika, chikungunya, and dengue fever. Climate change creates new uncertainties about the spread of vector-borne diseases by altering conditions that affect the development and dynamics of the disease vectors and the pathogens they carry. While transmission of the disease depend on a variety of conditions, higher air temperatures, rainfall, and flooding will likely accelerate the mosquito life cycle and the rate at which viruses replicate in mosquitoes. Next slide, please. The relationship between precipitation and vector abundance is complex. Although increased precipitations could provide additional vector breeding sites, droughts could also provide more breeding sites due to an increase in the use of containers for rainwater collection and storage, which are prime breeding sites for the mosquito Aedes aegypti. There is also the possibility of a decrease in the incidence of vector-borne disease in endemic areas when they become so hot that the vector survival or feeding are inhibited. Next slide, please. The most recent impact of a vector-borne disease in Puerto Rico was the 2016 Zika epidemic. Warmer climate may have facilitated the expansion of the geographic range of the mosquito populations and potentially increased their capacity to transmit the Zika virus. The outbreak that began in South America was spread by mosquitoes capable of transmitting the virus to areas including Puerto Rico, the US Virgin Islands, Florida, and Texas. Zika is a tropical disease spread by the Aedes mosquitoes, which also carries the West Nile virus as well as the yellow and dengue fever. The virus can be transmitted from mother to fetus during pregnancy and has been linked to an increase in miscarriages, death in newborns, birth defect, including structural abnormalities of the brain with and without microcephaly and of the eyes. Also, neurodevelopmental abnormalities have become apparent during the first months and years of life. Next slide, please. During the epidemic, 4,280 pregnant women with confirmed or probable Zika virus infections were identified by SABS and who documented 2,013 pregnancy losses, 4,015 live births, 68 infants were born with birth defect associated to congenital Zika virus infection, and 73 unknown pregnancy outcomes. These are cases that migrated before their delivery. Next slide, please. We are currently monitoring 4,015 live births and have documentation of 15 neonatal deaths, 9 infant deaths, that 797 infants no longer reside in Puerto Rico. Of the 3,194 that do live in Puerto Rico, 50 were born with birth defects associated with congenital Zika virus infection, and 81 have been diagnosed with the autism spectrum disorder. And 1,594 infants and toddlers are actively participating in the Children with Special Healthcare Needs follow-up program. And within these, 38 were born with birth defects associated to the congenital Zika virus infection. Now I'm going to talk about the 2017 hurricanes that hit Puerto Rico. Puerto Rico is particularly vulnerable since being an island, it faces rising sea levels from climate change and stronger storms as it's situated in the hurricane belt. In recent years, Puerto Rico has experienced the devastating hurricanes, which are increasing in intensity and occurrence due to rising global temperatures. 2 severe storms hit the island in September 2016, only 2 weeks apart from one another, Hurricane Irma and Hurricane Maria. Thank you. The timing of Hurricane Maria was particularly damaging because Puerto Ricans were still recovering from the damage that caused by Hurricane Irma, and were still without power, clean water, and were just starting to rebuild their communities when Hurricane Maria hit. The power outage in Puerto Rico after Hurricane Maria remains the largest power outage in the United States history. Hurricane Maria hit Puerto Rico on September 6, 2017, causing an estimated $1 billion in damages. 3 fatalities were documented, and over 1 million residents were without electricity. Hurricane Maria hit Puerto Rico on September 20, 2017, with sustained 175-mile-per-hour winds, up to 40 inches of rain. 9 of our rivers overflowed their banks, and the damage is likely to exceed over the $100 billion. 4,500 fatalities were documented, but something that they were even more than that. 80% of our agricultural fields were destroyed. 100% of the residents were without electricity. 60% were without drinking water. 92% of the telecommunications towers were also down. Next slide, please. Here are some photos of the devastation Hurricane Maria caused. Next slide. Government buildings were also damaged, and here are some photos of our workspaces after Hurricane Maria. We started working just 1 week after the hurricane hit, and we were sharing spaces and getting back to work to ensure that our MCH population was being taken care of. Challenges to pregnant women's health in times of emergency includes restricted access to healthcare, psychosocial and psychological stressors, and adverse birth outcomes. This study presented here documented the impact that Hurricane Maria had on pregnant women. They expressed fear of having the baby during the hurricane, fear of not having access to healthcare services, fear of having a negative outcome, including premature birth. This study explained the dual burden of protecting themselves and their unborn baby was evident in most of the participants' experiences. Most of the study participants narrated how they convinced themselves to stay calm and to cope with the situation peacefully as they could in order to protect their pregnancy. In Puerto Rico, 14 days after the Hurricane Maria, only 3 major hospitals were operating, and 16 days after, only 25 of the 78 hospitals were working. They experienced all the challenges of living without electricity, which took almost 1 year to be reestablished throughout the island, and with limited access to clean water and safe food. All of that they experience can definitely cause psychological and physiological stress on them. Natural disasters can be stressful situations for the individuals, and studies have shown that prenatal maternal stress could adversely affect fetal development, which could impact childhood and adulthood. I personally got to experience to some extent the impact of hurricanes because I became pregnant a little bit after the hurricanes passed, and I was still experiencing the aftermath and was living without electricity throughout my first trimester of pregnancy. And I do consider myself lucky because working in the division and our kind of work, I had the knowledge and was informed of the services and aids if I needed them at any point. But I did experience the worry of disruption of healthcare. And however, I did receive the care that I needed without any major delays or problems. Next slide, please. After hurricanes hit, infants, children and youth dependent on life-maintaining technology were in desperate need of help. Before the hurricanes, a centralized registry or statistics of technology-dependent children and youth in Puerto Rico didn't exist. During and after the hurricanes, these children were going to the hospital, not as patients, but as refugees. And the question of who would pay for their stay and their services they received arose. The division created a registry that was able to identify and collect the needs of this population, and later served as a liaison between the families, agencies, and foundations available to aid and ensure that these families receive the services and equipment they required. The registry identifies children that are dependent of life-maintaining technologies such as ventilators, oxygen concentrator, BPAP, CPAP, suction machines, cardiac monitors, nebulizers, and peritoneal dialysis patients from birth to 21 years of age. As of today, the 269 children and youth are in the registry. Access to and failure of generators was one of the main challenges for these families, as well as the fuel for these generators. As I mentioned before, almost a year passed before most of the power was reestablished throughout the island. And right after the hurricanes, many private practices and medical facilities were closed for a very long time, and these children need available healthcare 24/7. Some families also made the decision to leave Puerto Rico, but that also brought new challenges. The process of identifying and getting the necessary equipment for these patients and to travel, and all the clearances needed from the primary health provider to the specialists to the airlines were a complicated process. And then when they arrived at their destinations, ensuring that their health or medical plan covered outside of Puerto Rico the health services needed was another challenge. Next slide, please. In the last decades, birth in Puerto Rico has been declining. The situation has deteriorated drastically since 2016, when deaths exceeded births for the first time. That was the year the Zika epidemic occurred. It worsened due to the hurricanes, and if we compare birth in 2010, when 42,203 babies were born, and the year of the hurricanes, birth decreased in a 42%. And if we compare it to the preliminary numbers of births from last year, in the last decade, births have decreased at 55%. This has economic, demographic, and social unprecedented repercussions if this decrease in birth trends continue. Next slide, please. Can you click it again? It has an animation. Thank you. Another consequence of the impact of emerging threats and natural disaster is migration. In the following 4 months after the hurricane passed, almost 300 families monitored under the Zika pregnancy surveillance system migrated to the US. And we thought that most Puerto Ricans relocated to states like New York, Florida, or Texas, but what we saw was that they moved all over the US. This continuing migration also has economic, demographic, and social repercussions. As of today, more Puerto Ricans live in the US than in Puerto Rico. Thank you for your time.
Thank you so much, Camille, for that fantastic presentation. And thank you for sharing your personal story with your experiences being impacted by the hurricanes during your own pregnancy. I am thrilled to introduce our final panelist today. Jack Mateo is the legislative assistant for Congresswoman Lauren Underwood. He covers health policy for Congresswoman Underwood, including the Black Maternal Health Caucus. He also covers veterans, Social Security, and foreign affairs issues. And he's originally from Deerfield, Illinois. Jack, I'm going to hand it over to you now. Thank you.
Great. Thank you, Laura. And thank you all so much for the opportunity to be here today. It's an honor to be with you. Honor to follow two such extraordinary panelists. I'll try to be relatively brief so that there's plenty of time for questions. But it's so great to be with you and to be talking about such an urgent topic and to be talking about it on a really significant day, potentially here in Congress, which I'll get to in a minute. But you know, as Laura mentioned, my name is Jack Mateo. I'm a health staffer for Congresswoman Lauren Underwood. And Congresswoman Underwood is, by way of background, one of just 3 registered nurses serving in Congress. So she has a unique perspective that she brings to a lot of health policy issues. She served in the Department of Health and Human Services during the Obama administration and worked specifically on public health crises in the United States, including the Flint water crisis. And so she brought all of those elements of her background with her when she was sworn into Congress for the first time in January of 2019. Unfortunately, Congresswoman Underwood also brought the personal experience of losing a friend to the United States Black maternal health crisis. As some of you are probably aware, the US has the highest maternal mortality rate of any high-income country. The majority of the deaths are preventable. The rate is rising, and there are really significant racial and ethnic disparities. We know that Black and Native Americans in particular are 2 to 4 times more likely to die from pregnancy-related complications than their white counterparts. And so for Congresswoman Underwood, these statistics are glaring, but there's also stories behind each of them. One of her graduate school classmates, Dr. Shalon Irving at Johns Hopkins University, was a CDC epidemiologist, commission officer in the US Public Health Service Corps, and she died 3 weeks after giving birth to her first child, a beautiful daughter named Soleil. And it was in Dr. Shalon Irving's memory and in memory of all the people and stories and families that make up those horrible statistics that Congresswoman Underwood co-founded and co-chairs the Black Maternal Health Caucus, which she launched with Representative Alma Adams in the spring of 2019, just 3 months into her first term in Congress. And really, the primary goal of the caucus has been to identify policy solutions to tackle this crisis head on and to tackle the root causes, starting with systemic racism, and recognizing the need to do that in a comprehensive way. The result was the introduction of the Black Maternal Health Momnibus Act, which the Congresswoman introduced back in March of 2020 with then Senator, now Vice President Kamala Harris. At that time, the package included 9 bills to try to get at each of the clinical and non-clinical drivers of adverse maternal health outcomes in the United States. And while there were components of the package that addressed some of the issues that we're talking about today, the issue really came to the Congressman's attention in a significant way last summer when a new article was published in the Journal of the American Medical Association, which systematically reviewed 32 million births in the United States over the course of a bunch of different studies, and found really clear evidence that air pollution and extreme heat associated with climate change was driving adverse birth outcomes. Women and birthing people of color were disproportionately impacted, and Black families were impacted the most. And that really motivated Congresswoman Underwood to add a new bill to the Momnibus, which she worked on towards the end of 2020 and introduced early 2021. The bill is called the Protecting Moms and Babies Against Climate Change Act. It's included in the new Momnibus, which now has 12 bills. And the real most essential component of this bill is investing in communities, community-based initiatives, getting funding to people who are on the ground doing the work and supporting those most disproportionately impacted by extreme heat and air pollution and some of the other risks that we're talking about, specifically in the United States. And what's really exciting is this bill, the Protecting Moms and Babies Against Climate Change Act, as well as every single other eligible provision of the Momnibus, is included in the Build Back Better Act, which you might be hearing about in the news. It's this comprehensive package that Congress is currently working on as part of President Biden's Build Back Better agenda to really make long overdue investments on a variety of issues, including a lot of other robust climate provisions in the package. I think about $550 billion specifically in climate change provisions, but included within the maternal mortality section of the Build Back Better Act is the Momnibus and is the funding from the Protecting Moms and Babies Against Climate Change Act to go directly into communities and provide funding for the types of initiatives that we know are so desperately needed. So to give a few examples of what that might look like, it could be support for doulas, community health workers, and other perinatal health workers who can identify climate change related risks and support patients. Could be providing people directly with air conditioning units, appliances, filtration systems, weatherization support, and just direct financial assistance that families need during and after pregnancy. Support during and after extreme weather events like hurricanes, wildfires, and droughts. We know that there's funding in there to promote community forestry initiatives and tree canopy covers, improving infrastructure and blacktop surfaces, and improving monitoring systems and data sharing so we have a better sense of where precisely these risks are and what types of interventions are most desperately needed. So as I mentioned at the top, today's a potentially exciting day because we might be voting on the Build Back Better Act here in the House. So I apologize. I've been toggling back and forth as we're getting ready for that vote as early as tonight, hopefully by tomorrow at the latest. And if it passes, that'll put us just one step away from getting some of this critical funding signed into law. And for the Congresswoman, it's really kind of a two-track solution. One is, what are the really robust and comprehensive investments that we need to actually get at the root problem of climate change in the United States and worldwide, because that is really the underlying injury. But for people who are pregnant right now, they don't have time to wait. And if there are types of programs that we can implement at the community level to keep those parents and their babies protected during the perinatal period and the infant's young years, we need to provide that funding immediately. And you have investments on both ends of the spectrum in the Build Back Better Act, in the Momnibus, and Congresswoman Underwood is really excited to see this legislation get passed and signed into law as early as this evening in the House, hopefully soon thereafter in the Senate, get it over to President Biden's desk, and then continue to build on that progress with other legislation that we know is needed to combat this crisis. So happy to answer any questions you have on the Congressman's work on the Protecting Moms and Babies Against Climate Change Act, the Momnibus, or any of the other initiatives the Congresswoman and other maternal health champions in Congress have been working on to address this issue here in the United States and around the world. So thank you so much for the opportunity, and looking forward to answering any questions.
Thank you so much, Jack, for that. And with that, I am going to hand it over to my colleague Djan, who is going to lead us in our Q&A, facilitate our Q&A.
All right. Hello, everyone. I don't know you all, but I had a great time listening to all three of our panelists. I think that we have just a treasure trove of information that you all shared with us. And I'm really excited for us to get started into all of the questions that we have for you all, and all of the questions that our audience will be submitting and have submitted already. So thank you all for your time, and let's jump right into it. Again, you all have come to this conversation from a lot of different ways and different backgrounds. And so the first question I want to ask you all, just to start us off, is what got you interested in this particular section of MCH? I know Dr. Jyoti, you come from India and working with the Indigenous populations there, and Camille, you're working as an epidemiologist for Puerto Rico, and Jack from more of a policy perspective. But please just share with us a little bit about why you are interested in this particular section and how you've come to join us here. And I can start with Jack since he just finished.
Well, sure. I think, like I mentioned, for the Congresswoman, this issue of maternal health broadly was motivated not just by, this general notion that the United States is experiencing a crisis, but the personal experiences she's had with the issue, which we know are all too common for people across the country. And then this focus really on the intersection of maternal health and climate change and air pollution, extreme heat related issues, was in some ways inspired by that article, but we know that article just confirmed what people have actually been going through in their lives, which the Congresswoman heard about, for example, when she was working in Flint on the water crisis when she served in the Obama administration. So I think that was the motivation for her, and I'm just lucky to be able to try to support that work on the staff level, but it really has been her leadership here in Congress that has raised an issue that for too long has been overlooked and put it at the forefront. And like I said, we're now closer than ever to actually making some of these investments that are needed through the Build Back Better Act.
Thank you, Jack. Camille or Dr. Jyoti?
Well, I could go next if Camille, if it's okay with you. Well, I guess to be honest, my expertise is not on maternal and child health, but it is an important part of our larger program on community well-being. And as I was mentioning in my presentation, we had done a very extensive survey to get a sense of what are the sort of the health issues that we are seeing among the communities. I mean, through our observations and through our interactions with these communities, we do know that health is a big issue among the indigenous communities here, but to really get a sense of what are the real problems. And what the survey told us is, from the point of view of maternal and child health, the indicators were not looking very good. so a lot of our interventions were also sort of designed around preventive health. We don't really do much work on curative health other than linking communities to, sort of bridging some of the gaps in terms of access to public health services. Other than that, we don't really do any sort of curative health interventions, but really from a preventive point of view, we really wanted to address a lot of these issues around maternal and child health. And this whole new topic about the intersection of climate change and maternal child health was sort of is new to us as well. We know that, we see it, but really to sort of intervene with sort of that understanding that these are influencing each other, that has not really we haven't really sort of started looking at it in a more systematic way. And for me, this panel was really to learn from everyone what everyone was saying. I mean, Jack and Camille, your talks were so fascinating and interesting, and the kind of things that you're doing is really sort of inspiring, and hoping that we could do something similar here as well in a much more systematic and policy-driven, way as well. So that's what brought me here, not really to share my expertise, because I really don't have an expertise, but just to share some stories from this side of the world, really. But, yeah.
I just want to correct you, because I think you do have expertise, and I think that you brought such a rich amount of information to the conversation. So I completely believe that you have expertise. I'll pass it over to Camille as well.
So after everything that happened in Puerto Rico and everything we've been through these recent years, from the Zika to the hurricanes to earthquakes and now COVID, I just wanted to share our story so that in every aspect, since preparedness, maternal and child health is included in all of that process. And as an epidemiologist, the importance of the data, to collect quality data, and how this data can be used for action and policy to ensure that this population is being taken care of even before anything happens.
Thank you, Camille. I actually want to stay with you just for a second, because Dr. Joshi mentioned her newness in doing like surveys and really finding indicators to indicate, the different ways in nutrition and things like that. But I know you coming into this as an epidemiologist, so I had a question about like, what were some of the early warning signs or patterns that you might have noticed and first alerted you to the actual intersection or impact of climate change and maternal and child health?
So for me, the most graphic manifestation of the impact of climate change was after the hurricanes, and how the disruption of healthcare. As I said, only 3 hospitals were open right after the hurricane, and 1 week after, only 25 of the almost 80 hospitals that we have in the island. And if that was the status of hospitals, I imagine the status of private offices or those specialists that people go to. It was even worse. So yeah, it was a disruption of healthcare.
Okay. And actually, so now I'm going to switch over to Jack, because just to talk about some of the weatherization support that you mentioned within the bill. And now that also has me thinking about if there is also provisions for emergency preparedness in that way, like that Camille spoke of, like when something like this happens, what kind of weatherization support specifically to support the maternal child health population is available within the bill as well. And I know you're like, I'm really excited for you as well for today, maybe a vote, maybe tomorrow, maybe a vote. So I'm hoping that pushes through as well.
Yeah, thank you. And I think, the most critical aspect of the funding is that it's not a top-down approach. It's not the federal government telling every community what interventions they need to implement, but actually getting the money directly into the communities, community-based organizations that are leading the way, that know the needs of families, and can use that funding in a flexible manner. So there's a significant amount of latitude within the parameters of addressing these risks. But the funding goes directly to local health departments, to community-based organizations, to healthcare professionals on the ground who are directly interacting with the families who are impacted. So there's not like a specification in the law that this is the type of weatherization that you need to implement, or you need to give someone an AC unit. In some cases, we know people might have AC units, but they might not have the means to pay the bills to keep it on. And that's why there's that direct financial assistance. And so, again, we think that the expertise lies within the communities. We just need to get them the resources to amplify, expand, and enhance the work that they've already been doing. And that's true on the weatherization front and really all the interventions throughout the omnibus. And I think that's unprecedented in the approach here in terms of what the Congresswoman has set out to do. It was really inspired by something that Elizabeth Dawes-Gay, who's one of the co-founders of the Black Mamas Matter Alliance, Congresswoman Underwood hosted this stakeholder summit right when the caucus launched that first year and asked all these groups to come in and share recommendations. And Elizabeth Dawes-Gay's recommendation was pretty simple. She said, listen to Black women, trust Black women, invest in Black women. The answers to this crisis lie within the Black community. And I think that is true for all the communities impacted by these issues. These are not problems without solutions. It's not something we have no idea what to do. People are actually doing the work on the ground. They just have been doing it without federal resources. And Congressman Underwood set out to provide them with those resources, which we think is going to save lives and advance equity in communities across the country.
Thank you, Jack. I love that. I actually have a shirt with all of those words on there. So I'm really, really glad to hear that. I actually have like a quick follow-up, just because I like to make things like super simple. So would it mean just women or patients expressing interest in, hey, I need an AC unit, or hey, I need financial support to their provider or whoever, and then just applying and receiving that?
Sure. So the funding would go, basically the way the bill is structured, it's the applications come at the community level to HHS. So it could be, and one of the requirements is that whatever entity is applying for that funding, it could be a consortium of different groups, it has to include a community-based organization. So it could be a community-based organization plus a local health system, plus a local health department, or plus a pediatric practice. But it's got to have a community-based organization because we think they're going to have the most touch points. So once that funding goes to the applying entity, that consortium of the community-based organization and local health department and health system, then they're able to work directly with the patients and meet those individual needs.
Thank you so much, Jack. We also have a question in the chat, so I'm just going to read it out. Great presentations to all. Do folks on the ground, both in MBR and Puerto Rico, both feel that rising temperatures are affecting maternal health and sense of well-being? I know that specific crises like hurricanes and Zika are very significant, but the seemingly non-crisis chronic events also impact stress levels / perceived stress levels. I guess Camille or Dr. Jyoti, either one of you can start.
I'll start this one. Yes, definitely. Puerto Rico is getting warmer. It's November now, and I feel like it feels like we are in summer still. But if talking about temperatures, we like some would say get an air conditioner, you have the facility. But in Puerto Rico, another consequence of getting an air conditioner is the rising prices or what they charge for electricity. It's continuously rising. Just this last month, another percent was the price rose. So yes, some people cannot. It's almost like a luxury in Puerto Rico. So yes, the well-being. Yes.
Well, in the case of the Nilgiris, where we are from, we're in the hills really, and we sort of have the opposite problem. This whole year has been so wet and cold. We don't even remember. I don't think we had summer this year. It has been raining. It's in fact in Tamil Nadu, 21 districts are on red alert, and all schools are closed because of really bad rains. And we have been getting rains throughout the year. The temperature has always, it's been just cold and mist, and it's been bad. Now, I really don't know how to answer whether, these sort of climatic conditions have had some sort of a direct impact on maternal and child health. I don't know the answer. I'm assuming there must have been, because it's sort of generally affecting everyone's day-to-day life and general well-being. So that's a sort of a easy assumption to make, but we haven't really explored it in that sort of a very systematic way. But I think what has really affected lives in these hills are the erratic sort of weather that we have been experiencing with extreme weather events like flash floods and rains and landslides and so on. So that has really disrupted the way of life here in the hills. And so then it's sort of an easy assumption to make that it would have also affected stress levels and anxieties among communities as well, especially when a lot of their work is more outdoor based, right? They work in the fields, they work in the plantations, they work in the tourism sector and so on. So when you don't have really good weather, then all these activities are also affected. So so that has been our observations from the ground here. Yeah.
Thank you, Dr. Jyoti and Camille. It seems like even though you're on, two separate, continents, like you're seeing the similar effects. Actually, Camille, I wanted to go back to you because you spoke a lot about the feeling of fear and a little bit of the emotional toll. So I wanted you to actually kind of expand a little bit on that. And then also I had a question about are there any plans that the department has to sort of address the mental stress and toll that that women are feeling?
Yes, the government do have resources on health programs or under AMCHP, which is an office that evaluates and certifies private and public agencies that offer mental health services. And I think that the most public service or thing that they have available is called the Linea Paz, where they can call 24/7, 365 days a year. And they help counseling, emotional support, preliminary screening of on the psychosocial level, in suicidal behavior, and other mental health problems. So that's available for anyone here in the island.
I also have a follow-up question, I guess, about how the government goes about letting people know about these services. I know you mentioned that there was a little bit of a privilege there and that you have this inner knowledge of how the department works and what services are available. So I'm asking, I guess, how does that message sort of get out, especially when there's such compounding crises and concurrent crises that happens? So if you could speak a little bit more on that.
I think when the hurricanes, like the most strategy that the government uses is through telecommunications. I forget, like in the TV and radio, but in the hurricane, the telecommunication was down completely. And I know that before the hurricanes, there was a lot of telling people that all of these were available, the numbers that they had to call, the nearest fire station and police offices for each municipality. So beforehand, they did inform. And after, even though there was a lot of time that we were uncommunicated, I think that the municipalities also moved very well to ensure that their communities were okay. And after the earthquakes, so many people learned and already knew about these services. But yes, the municipalities had to move, and us, for example, as the division, we had to make sure and find all of the population, the target population that we have, just to make sure that they're okay. And I know that we did that outreach to our population under our monitoring our target populations.
Thank you for that. So clearly it seems like there's a lot of pre-work that goes into making sure that people are aware of the services. So thank you for sharing. Sorry for jumping around like this, but Dr. Jyoti, I'm going to go back to you because I know that you also mentioned in your presentation the importance of community autonomy or community leadership and autonomy and having the decision-making role within environmental governance. And so I wanted you to speak just a little bit about that and tell us a little bit more about what it means to have autonomy in this area and how it affects well-being in maternal child health populations. Actually.
Sorry, I'm sorry.
With any population you would work with, actually, just the general importance of community leadership and autonomy.
Yeah, yeah. No, that point was in reference to our work with Indigenous communities here in the NBR, and it does have a lot of significance, because the communities have always been part of the forest landscape. The forest is their home and has always been their home, and but because of various I guess socio-political issues, a lot of times these communities are now being kind of separated from their land. And with this new law that has come into effect in 2006, and interestingly, it's been what now, more than almost 18 years now, I guess. Did I get the math right? That people are still in their process of claiming their rights. And so I think the way we sort of kind of want to address this issue is by not only just facilitating these rights for the communities, but also to develop capacities within the communities to be able to assert their rights, collectively ask for their rights. And these rights are constitutionally provided rights. So it's not like they're just asking based on some sort of an historical relationship, but it's been a constitutionally approved right, and yet they are struggling to receive it. So that kind of sort of suggests the kind of vulnerability and marginalization that these communities face, and the fact that these communities are very small in number and they're scattered in population, and they're also very culturally different. So even though they are indigenous communities, what is unique about the landscape is that there are some sort of 6 or 7 different indigenous communities that reside in the landscape, and they're culturally very different, and they have very different associations with the forest as well. The only way that we can sort of raise their voices by bringing them together. That collective voice would be much more powerful than individual individual voices, or even individual community voices. So that has been our effort in really developing capacities among these communities, identifying leadership, and sort of nurturing those leadership, supporting in a lot of the advocacy work that would help them in terms of getting these rights to sort of then be able to make decisions and govern the forest resources and decisions around forest management, which would then go back to the community's hand. Right now it is with the state, and the state as a powerful player can do a lot of things, and only if these rights go back to the people that they will be in a position to sort of exercise it. So that has been a lot of our effort in terms of nurturing leadership and facilitating this process.
Thank you. And I think I have a follow-up question.
I know I sort of missed the point about the linking with maternal health and all that. And the point being that only if you have access, you will have access to the resources that are in the forest. And, and that has direct implications on their health as well, because, we do a lot of effort in reviving practices around traditional practices around food and wild food. And so I think the basic sort of link is access, and without rights, you don't have access, and without access, you don't have access to these foods as well. So I think that would be the direct link there. Yeah, sorry to interrupt.
Okay. Thank you for making that link. I was actually going to ask a follow-up, because I think it's a little bit frustrating to hear, because it's sort of like what Jack was saying about really incorporating community leadership and community voice and how important that is. And I know you said in your presentation something about knowledge sort of staying within the community, and these people who have direct knowledge about the land, the community, how things work, them needing to have the right and the say so. And so it's kind of frustrating to hear that there's still this sort of tug of war between that. So I wanted to see if you could speak a little bit more or offer examples of how increasing knowledge of cultural practices and traditions related to the environment also helps sustain nutrition and food sources and things like that. So how those sort of cultural practices link to sustain and improved nutrition.
Yeah, so as I was saying, so as part of our efforts in facilitating these rights, a lot of the communities have been successful in receiving their individual forest rights. And what this means is that, they have land security, which sort of protects them from being evicted without any consultation processes, which has happened. And you probably hear stories about, not so much here in the NBR, in the Nilgiris, but you would hear these stories from, Eastern India and places like Jharkhand and Orissa, which are predominantly tribal, states. And you also have very powerful mining corporations who can be sort of very influencing, agents in decisions around forest management and forest land use. But here, what has happened is with the individual forest rights, communities have now land on their name where they can decide to, grow what they want to grow and not necessarily be driven by outside market forces, for which, again, Keystone's intervention, we've been able to set up a local tribal FPO, which is a farmer producer organization. So that sort of allows communities to decide what they want to grow, how they want to grow, not influenced by market pressures. They also have a sort of access to markets through the tribal FPO. And so these are some of the arrangements that have helped these communities to, to sort of decide in terms of, what sort of food they should be growing. So as as part of my presentation, I was talking about this increasing dependency on the public distribution system, but the kind of food that you get in the distribution system is very rich on, carbohydrate rich and sugar and so on. There's nothing really in terms of what's the word for that? From a nutritional point of view, it is really not the best. So with this, what has happened post the IFR, the individual forest rights, is that communities have gone back to their traditional, practices on around farming. So a lot of them have gone back to growing millets, and these are all usually mixed, diversified farms. So that each farm of an acre would have about 3 to 5 different kinds of millets growing on them. They would have some sort of lentils growing on them, and so this becomes not only ensures food security, but also nutritional security as well. And a lot of our efforts in reviving these traditional practices on agriculture has sort of led to this shift in, shift in sort of farming practices among these communities. And we are now and simultaneously the interventions on health, where we are constantly talking about how the nutritional value of these traditional food systems. So when you're doing these kind of efforts simultaneously, it seems to be having some sort of a impact on the community, and you see these lifestyle changes in terms of food practices and what they consume and so on. We kind of are at least starting to see these changes on within the communities that we work with. Yeah. I don't know if that answered your question, but yeah.
No, thank you. Thank you for explaining the entire life cycle of that. And
Sorry.
You're fine. And thank you for explaining how that all works. And also, and I should say, as we're talking, Jack, Camille, and Dr. Jyoti, feel free to share resources either in the chat or to me. We can share that after the presentation, just so people can kind of see like the cycles that you're talking about, the work that you're doing. I know Jack has a few web pages on the bill, and so we're happy to share all of that information as well. Jack, I'm going to throw a last question to you, and then I'll have one last rounding out question for all three of you. But Jack, I'm just curious, just because of the few weeks that we've had with COP26 in Glasgow. I'm just wondering if you saw any gains from that would make a major difference to the MCH populations that you want to speak on, or I invite you to talk about any excitement around the bill in general, especially considering today.
Sure. Well, like I'd kind of mentioned earlier, there's this 2-track approach that the Congresswoman's thinking about. One is, how do we actually mitigate the underlying risk and, address the fact that we have extreme heat and air pollution and the drivers of those risks? And then two is, for people who are pregnant right now or about to become pregnant or just finished their pregnancy and they have a young baby, how do we protect them against those risks? And so the Momnibus includes a lot of important initiatives on that second track, making sure that we can get the direct financial assistance or the AC units or whatever the individual community needs might be. But the Momnibus itself is not going to prevent 2 or 1.5 degrees of Celsius increase in average global temperatures from pre-industrial levels. That's going to take, global and really significant action. I think the general consensus seems to be that we took some important steps in that direction through Glasgow, but there's a lot more work left to do. I think there's optimism that this lays a foundation to take those steps. And if we do them, it's going to have really important impacts for moms and babies, because as Congresswoman Underwood always says, we talk about this like abstract number of 1.5 or 2 degrees Celsius. Nobody actually can conceptualize what's if I told you right now here in Chicago where I am, it's 32 degrees, which is Fahrenheit. But if I told you it's 34 degrees Fahrenheit, you'd probably just say it's cold. So it's hard to conceptualize what those 2 degrees mean. But climate change is not an abstract threat or even just a future threat. It is actually killing moms and babies, including right here in the United States right now. And so we need to make investments immediately for people who are impacted at this moment and will continue to be impacted with exponential effects into the future.
Great. Thank you so much, Jeff, for rounding us out. I actually have 2 questions because I can't choose which one I want to ask you all. So 2 things, considering the amount of people that we have with us here today and who are joining us from different parts of the world, what suggestions do you have for folks attending this webinar who would like to take action to address climate change or focus on climate justice, but who work at organizations where there are political climates are not receptive to that? So that's the first question. And the second is just, what do you want people to take with them today? What do you hope the attendants would take with you today? So we can start out with Jack, since you just finished, and we can go to Camille, then Dr. Jyoti.
Sure, thank you so much. In terms of next steps, like I said, passing the Build Back Better Act is immediately in front of us. So if you're here in the United States, contact your members of Congress, your representative, your 2 senators, make sure they're on board and understand the sense of urgency that we feel to make these investments that we know are needed. If you want more updates from the Black Maternal Health Caucus and the work the Congresswoman is doing on the Momnibus, you can follow her on Twitter at Rep Underwood, or follow the caucus, or I should say, and follow the caucus on Twitter at BMH Caucus. You'll get more updates. And I think as a final takeaway, just this recognition that the Congresswoman has talked about, that none of this is abstract. The U.S. maternal health crisis is not a bunch of abstract statistics. Climate change and climate justice are not abstract concepts. These are actually people's lives being impacted every day, and the sense of urgency is great, and the need is significant, and we need interventions that meet the scale of the problem. And I just appreciate everyone who's participating in this conversation, because I think you all are doing that work to meet those needs, and looking forward to working with you in the United States and globally moving forward. So thank you so much for having me today.
So my suggestion would be, maybe it's a little bit on the epidemiology side, but my suggestion would be to document in detail the problem, its effects, and take that and with ideas on how to manage it. And if you're thinking of preparedness, you can take examples of other places that have experienced the impact of climate change and take it to key stakeholders or personnel within your organization that can help make that changes. The thing that I would want attendees to take with them is that the importance of the Title V program and how they serve as the foundation for all of these services that mother and children health get in Puerto Rico, and that if they have the power to make sure that this population is included and it's made a priority since the preparedness. That's what I want, just to make them and be sure that they're included in all of the processes.
Well, to the first question, I guess I would say that, as Jack was saying, climate change is not an abstract concept, and it's a real thing, and it's really affecting people's lives every day. And I would say one way of addressing it would be, would be to sort of documenting a lot of these stories. Stories can be very compelling, and these are real stories affecting real people in real lives. So documenting these stories and sharing these stories and talking about these, these second-hand or first-hand experiences and narratives that you hear from across the world can be a very powerful tool to sort of influence people and, sort of bring people to the side of the conversation. So that's one. The other point about what to take away, I guess, is that, we've been talking about climate change and maternal and child health, but these linkages, they're not that simple and that sort of straightforward. The way I see climate change, there is a physical aspect of climate change that we see every day, the temperature rise or the temperature fall or the extreme weather events and so on. But there is also the more complex social, political, and economic factors that are influencing a lot of these outcomes that we see, and to sort of try and understand those as well, to try and sort of connect the dots and bring some of those kind of narratives out to the open, and especially if you're in academics and if you work with policymakers, bringing those stories out and really sort of pushing people to think beyond what they see is something that I would want everyone to think about and consider. Yeah, and come visit us in NBR and work with us as well.
Thank you all so much. That was wonderful. And I really, really enjoyed hearing more from you all. And yes, and our attendees are promising to come visit you, Dr. Jyoti. So thank you all for your great words and your great presentations as well. Linda, my colleague, has put into the chat our evaluation. So we hope that everyone can fill that out really quickly. It takes like maybe 2 minutes. And I'm going to ask Salome or Noelle to put up the thank you slide. And again, I'm just going to re-put this link into the chat about our evaluation. And thank you. Thank you for sticking with us, guys.
Thank you. And lovely to meet everyone. Thank you. Bye.
Bye. Bye all. We can close the webinar now.